How does obstructive sleep apnea relate to temporomandibular disorder? Again, we've got enormous numbers to, sorry, whilst I just get us some technical difficulties here. We've got enormous numbers today, all over the place, with well over 120 registrants from Australia and New Zealand, India, UK, and Malaysia, from all around the globe. Welcome to Race Academy webinar series again. The feedback from last series or the last episode was phenomenal, so if you do have any questions, I do ask you to keep them till the end or log them on as we go, and I'll read them out at the end for our fantastic speaker. We've managed to talk him into coming back and delivering again. He is extremely famous across Australia, not just for winning the long jump at Little Athletics, but for being the Australia's longest and most prolific specialist in the temporomandibular and sleep apnea arenas. So with no further ado, again, keep your questions coming. We do appreciate that there will be a lot, and I'll do my best to get through. But with no further ado, I hand you over to Professor Michael Stubbs.
Thank you, Matt. Thank you very much, and welcome, everybody. This is a really enjoyable opportunity to, I suppose, speak to colleagues and share information, and I really appreciate the opportunity, by the way. I can't take the fame for being the longest temporomandibular person in my specialty. There are a few guys a bit older than me, grey hair, etc., but I really appreciate the compliment. This is an interesting topic, temporomandibular disorders and sleep apnea. And I'm going to come at this from a two-part perspective. The first is, how does sleep apnea relate to a patient who presents with the symptoms that you diagnose with TMD? Second, if you have a patient with sleep apnea who has TMD, how do you manage both? And so we're going to talk about both elements as they interrelate. So we know that TMD from previous presentations is a musculoskeletal pain disorder, and really we're talking about pain associated with the temporomandibular joint, masticatory muscles, and particularly ear pain, pre-auricular pain we call it. So in other words, some patients can present with pain very localised, some patients can have quite generalised, it can often be bilateral, unilateral. The interesting observation I'll make is that when a patient presents with TMD symptoms unilaterally, don't be surprised if the so-called unaffected side is more painful to palpation than the affected side. I mean, interesting observation, but you will find that that's not unusual. And we also understand a bit about bruxism. I gave a talk earlier this year on the types of bruxism, and it is a very academic type categorisation, because let's face it, what is bruxism? Well, bruxism really means the grinding or clenching of teeth and the thrusting or bracing of the mandible. And we know that with bruxism, you can divide it up, as I mentioned in previous talks. We say sleep bruxism and awake bruxism, quite simple. And the reason it's interesting to do this is because certain disorders, certain conditions, certain medications can upregulate the experience of bruxism, day or night. And more importantly than that too, we recognise that not everybody bruxes just because they're stressed. And I think that's an important observation as well. And, you know, when you say to your patient, for example, do you grind your teeth? It's really not a great question to ask, if you don't mind me saying, because number one, most people will say, well, I don't know. And number two, they'll tell you that their husband or wife, partner never says anything about making noise when they're going to sleep at night. But I think what's interesting, remember, clenching is silent. So, you know, always bear that in mind. And we know that in sleep bruxism, for example, about 8% of adults are thought to brux on a regular basis at night. And we know about 20% of average patients who have bruxism during the day. These are estimates. And one of the issues about these comments I'm sharing with you in the numbers is this is based a lot on self-reported bruxism. So what it really means is that somebody might say, yeah, I grind my teeth. And the question is, well, how do you know you grind your teeth? I mean, yes, we can look at the worn teeth perhaps as an indicator. You can see in this photograph here, we've got the scalloping of the tongue, which is often a dead giveaway that there are issues perhaps with bruxism as a factor, because clearly at night when a patient wakes up in the morning, they have this scalloped edge. It means the tongue's being thrust amongst or along the, usually it's the mandibular dentition. But also we understand that when we go to sleep at night, it's not a matter of just closing the eyes and then waking up in the morning. It's called the circadian rhythm. And we go through these, what we call sleep cycles, which means, as you can see in the diagram, top part of this slide says non-REM stage 1. So in other words, we can divide sleep up, if you like, into REM and non-REM. REM is the dreaming part. REM is the part of sleep where you feel this sense of regeneration, refreshment. So if you don't get enough REM sleep, you actually often will feel fatigued or tired, lack of refreshment in the morning. And people who have sleep apnea or other sleep disorder breathing issues where they don't quite get enough of the percentage of the different distributions here of non-REM, light stage 1, 2, non-REM stage 3, 4 we call deep sleep, and REM, of course, is the dreaming part. You go through these 90-minute cycles. And so most of us, when we go to sleep, might go through 4, 5 or 6 of these types of cycles every night to sleep. And it's about the distribution of these cycles. And the relevancy is that when you have bruxism, most of the bruxism tends to occur in the early stages of sleep, about 80% actually, in the non-REM stage. And one of the things I interpret from that is a patient will often say, I wake up in the morning and I'm aware I'm clenching my teeth. But of course, during the course of the night, they've probably done it on quite a frequent basis. And I think the other thing that I always advocate is that when you see a patient and you're asking questions, you know, do they grind their teeth? Do they clench their teeth? Ask them, is their jaw sore, painful or stiff in the morning? Because often I think that's a more realistic indicator that there's been activity of the jaw, the mandible at night. So in this indication, I'm just showing you that the relevancy of looking at the sleep cycle is because we know that in some patients, sleep apnea, a consequence of sleep apnea is you get the disturbance in the sleep cycle, but you also generate bruxism events as a result of the patient coming out of the apnea event. Now, again, that was another presentation I did, but for the purposes of those watching this who aren't sure exactly what apnea means, apnea, sleep apnea comes 95% of the time. It's usually mechanical, which means the throat becomes blocked, the tongue obstructs the airway, the patient gasps to breathe, the brain recognises those changes as happening, the elevation of CO2 happens, the oxygenation levels start to deplete or to reduce anyway, and the brain recognises the importance of switching on the reflexes to reopen up the airway. And so the patient slips from the REM stage, which is where a lot of sleep apnea tends to occur, because REM stage means you're sleeping in virtually a situation where all your skeletal muscles are relaxed, they don't work. And the REM stage means rapid eye movement. So usually just the eyeballs are moving from side to side, and you get great blood flow to the brain, which is part of the life cycle of the brain. It gets rid of metabolites during the course of the night's sleep. And so in those cases where they're getting apnea, they go straight back to the light stage sleep and they get the opening up of the airway. And as a result of that, they get this change in percentages of light sleep, deep sleep. So you might say then, well, what's the relevance of this to TMD? Well, it's actually interesting because in some patients, the bruxism can be such that they can be munching away in stage 1, 2, and they wake up feeling tired because the bruxism is disturbing the sleep, not necessarily sleep apnea. So that's the relevance of this. And also recognising in your patients, you're treating or diagnosing one condition, but always take a step back and look at the big picture. We use the term holistic because often you might find what you're looking at is part of the problem, not the whole problem. And so, as I mentioned a moment ago, we can see obviously the rough percentages of when patients tend to sleep brux. Remember, 8% of adults estimated to brux on a regular basis. I think it's probably fair to tell you that most of us in life at different times of our life will do bruxism events. So it's not an extraordinary event. The problem you have is that patients who have pain in their jaws, or they've got sensitive teeth, or they've got issues where you're looking at loss of tooth structure, then, you know, bruxism is very important, isn't it? Because you want to protect the work that you're going to do to restore the dentition. You're also looking at the patient as a whole and trying to also help them with any jaw pain that they experience. The interesting thing is too, it's estimated that less than 3% of adults brux over the age of 65 years. Now, again, these are studies conclusions looking at populations where people self-report they brux, which is not that reliable. The ultimate reliability is having a sleep study. So just highlighting this before I go on, sleep bruxism tends to occur mostly during the lighter part of sleep, and recognising that when you have what we call a sleep study, and this gentleman's getting wired up for sound here, and you can see all the arrows moving around, and what that's really saying is that he's got some bands on his chest and his abdomen to record movement of the chest and abdomen. He's got a nasal airline which regulates the flow of air to the lung and back. He's also going to have some EEG, which are electrodes on the brain. That's how they can work out the sleep cycle percentages. He's got a finger probe, which measures his oxygen levels, heart rate by the flow of blood through the fingertip. And they can monitor, therefore, blood pressure, changes in blood flow. And in particular with this too, how much of the time he spends on his back, his side or his front. And the value of this is that we use EMG attachment, so masseter or submentalis, to actually see or record the amount of movement of the mandible. And so those useful aspects for when we talk about a patient who's got TMD and you suspect bruxism is an issue, a contributor, the value of having a sleep study is you're not only confirming how much that person bruxes, and remember too, folks, that when most people have one of these studies done, it's a one-night event. So therefore, one of the problems science has in studying bruxism is that sometimes people get wired up for sound like this bloke, and in reality, he didn't do much. And then the next night when he wasn't wired up for sound, his jaw went ballistic. So we recognise that this is good, this is objective data, but again, not every patient needs a sleep study, but the value of considering this is when we're about to talk about some of the questions you should ask your patient before you start to lunge into the planning, perhaps of making a nice raised dental occlusal splint for the patient. And I'll talk about that in a moment. And again, for those of you who've watched this before, I appreciate, sorry, I'm telling you things you already know, but there might be people watching this for the first time. We know that with a sleep study, what we're really describing here, you can see all these wiggles. Now, these are all recordings of different elements associated with that gentleman that had the sleep study attachment. So we're looking at brain waves, we're looking at the chin movement, which is relevant to the issue of bruxism along here. And you're looking here, and I've highlighted this for you. You can see when we look at airflow, what happens is when someone stops breathing, apnea, for more than 10 seconds, you can see here that the actual oxygenation drops, they stop breathing literally, and then when the brain starts to recognise this is happening, straight away go into light sleep, reflexes kick in, airway opens up, and all of a sudden the chest and the abdomen start to work as they would, so they're hyper-working here. And if you have a look, there's snoring, and then suddenly when they're obstructing, there's no snoring. And then they go, you know, like that as they come out. I'm only doing that once. And then the bruxism events is where they're coming out because you get this surge of adrenaline. So you can see that in a lot of cases, not everybody, people that have TMD where there's a bruxism issue that might be a driving factor for the condition, not necessarily causal for TMD, sleep apnea might be relevant. And the biology behind me saying that is based on what you're looking at in front of you. As some patients have driving factors for the bruxism, which might be sleep disordered breathing related. And you can see this gentleman here, obviously, dare I say, a Jenny Craig failure, but he's actually wired up for sound. He's got a little tiny microphone here, which records the noise he makes. He's got the oxygen flow and so on. And again, we can get an idea of movement of the mandible in a very objective way. That's the value of a sleep study for us, bruxism. But it's also valuable because we're looking at it in the terms of how can we look at our patients, and is sleep disorder breathing a driving factor for the patient's presentation of a sore jaw. And to summarise what I've just said, literally what happens is as the patient goes in and out of these apnea events, you get the surge of sympathetic activity, you get rises in heart rate, blood pressure, and particularly activity in the brain. You go from deep sleep to light sleep, and more importantly than that, you get activation of the masticatory muscles. And the benefit of this is it's helped to stabilise the opening of the airway. And so, of course, what happens is you can imagine my fingers of the jaw, you get this profound bruxing, and then it stops. And then throughout the course of the night, you might go through these bursts of bruxism events. So you might say to yourself, well, that's really interesting, But how can I apply this knowledge in the context of how I'm going to assess my patient with TMD? Well, let me tell you how, because I think it's really interesting. We understand that, again, just showing you, again, much in a simpler format, the issue of the cessation or stopping of breathing, and then when they come out of the issue, there's the bruxing happening here. The trap is, folks, don't fall for the idea that every person that you treat who has a sore jaw must brux and must have sleep apnea, because it's not true. What I'm doing is giving an opportunity to screen your patients, to work out which ones might need more input, which ones don't. And so this is a very famous one called the Stop Bang questionnaire, 8 questions. Now, in Australia, unfortunately, dentists, myself included, we can't refer a patient off for a sleep study if the patient expects to get a Medicare entitlement. Other countries, different rules. But in Australia, what we use this for is to simply say to your patient, you can imagine they're telling you all about their jaw history. You've already got a good history from previous talks I gave about how to interpret TMD symptoms, ear pain, any headaches, pain or tiredness of the jaw when they're chewing, waking up in the morning with a stiff or sore jaw. That's really great stuff. But then you can say to the patient, do you snore? Have you ever been told you snore? Do you feel tired when you wake up in the morning, unrefreshed perhaps? Has anyone ever witnessed you or told you you stop breathing during the night? You look at the medical history. Are they treated for high blood pressure? Are they overweight? Are they over 50? Let me tell you, folks, people under 50 can get sleep apnea too. Neck circumference, greater than 40 centimetres. You don't have to get a tape measure out. You can ask what size collar they use. So usually men, more than 42 centimetre collar is a risk factor for neck circumference for sleep apnea. And obviously, in this case, a male is a higher risk. So if the person scored 3 out of the 8, just before you've even examined your patient, potentially you have a patient who might have sleep disorder breathing as part of a consideration when you're working out how you're going to treat these patients for TMD. And the Epworth Sleepiness score, again, some of you may be very familiar with, does not mean that if they tick all the boxes, they actually have sleep apnea. What it tells you is that they're tired, and tiredness can be a symptom of sleep apnea. And as I said earlier, remember, bruxism sometimes can be so profound that when they have a sleep study, they don't have sleep apnea, but in fact, the bruxism itself is actually causing changes in deep sleep to light sleep, and that's what's making them feel tired. And again, we score this based on the presence of, when they're sitting and reading the newspaper, do they drift off to sleep? None, which is 0. Very likely a score of 3. The patient feels this in themselves, perhaps in your waiting room before you meet them. Do they watch television at night? That's usually, in my experience, a dead giveaway someone's tired, particularly if they say, I can never watch the end of a movie. I'm always asleep. Being a passenger in a car is another great experience, one where, again, it might indicate the patient actually has tiredness issues. They struggle to keep their eyes open when they're a passenger in a car. And some people, for example, have to have a nana nap or a cat nap in the afternoon. And some patients, even after lunch or having a drink of alcohol, they struggle to keep awake. Again, this is a scoring technique. It's simple. Patient can fill this in before you see them. You can then examine them and ask them all the right questions about TMD assessment, and then you can ask them the stop bang questions. You see, the point is when you add these scores up, imagine if they were 3, 3, 3, 2, 3, 3, etc., you get an average rate of how tired they are. And so the relevance is, do you have a patient who's got TMD who may also happen to have obstructive sleep apnea, and therefore the validation of getting a study done before you treat them, perhaps with considering an occlusal splint. So you might say, well, does that really matter? It does, because what happens when you put an occlusal splint, well-made one, in the mouth? Tick-tock, tick-tock. The tongue has reduced volume of space, and that's why sometimes some patients complain that they snore more. And if you think about it, you've got a patient who's got sleep apnea, undiagnosed, and you make them a well-fitting splint like you can see here. This is a flat vein splint, which I talked about in my previous talk, and of course the famous Michigan. You're actually potentially increasing the severity of the sleep apnea just because the tongue has less room. And that's the value of knowing what you're treating before you start treating it. And we know that in cases where you then say a patient comes back, they've got TMD, and they need a dental device, a mandibular advancement splint. What's some of the basic principles that you might need to consider before you treat them? Well, the first one is, if you look at the literature often says patients with TMD contraindicated to have a mandibular advancement splint. I have to say, I don't accept that. It's all about really how rapidly you advance the mandible and where you start them in a forward position. So I'll give you an example. When we use a gauge, one of them is called the George gauge, we look at centric occlusion and we look at maximum protrusive range of the mandible, and we can make judgments in millimetres what that range is. Let's imagine it's 10 millimetres. Now, normally in a mandibular advancement splint, in my experience, I'd start them at 50% forward. But you've got a patient here with TMD. They're not going to tolerate that. So you might start them at 10% forward. And you'd also share with the patient the fact that it's going to take a long time to bring them forward, but you're working with the sore jaw and you're keeping their airway open. So you can see how, even in just considering the benefits of treating a patient with a TMD and then getting a study done, your whole treatment's not about just an occlusal splint. You're trying to also help the patient with their airway issue and treat the TMD. And the basic principles, folks, again, for those that didn't have the opportunity to see my previous talks, always make sure whatever device you make for a mandibular advancement splint that you have freedom of lateral excursions and that they can be titratable or adjustable. That's really important basic principles, because with the advancement potential, you can adjust them. The patient's jaw has time to adapt to the impost of being pulled forward, and having lateral excursions reduces aggravation of TMD because the patient can still brux. Now, in this one, this is an MDSA which Race Dental make. They make the MDSAs as one of them. They make, this is I've put in there, you can see it's got two parts. Upper has a hook device, the lower one has a flat plate, if you like, and in the mouth, the hook attaches to the plate and holds the mandible forward. Again, have a look at this image. The patient can slide laterally, no problem. And of course, they can't open their mouth, which for some people might be a problem, claustrophobic, but for a lot, it reduces the snoring and you don't have to therefore bring them maybe as far forward. And these are adjustable, as you can see in this case, by a key which turns, and so it brings the mandible forward in 0.4 millimetre increments. Again, this is about someone who you may have presented with TMD and suddenly also has sleep apnea. The Herps device is another good alternative. There are dorsal fins. There are lots of different design devices that exist in the market. And my suggestion to you folks is always choose a device that you're comfortable to use. And the basic principle is always make sure it's two parts, it's adjustable, and it allows for lateral excursions of the mandible. And when we're titrating the mandible forward, as you can see in this image, this gentleman's, his chin is slowly being brought forward. Obviously, the tongue's coming forward along with the ride. We're actually opening up the airway. And in this image here, we can see where the tongue is being held forward. The sleep device is situated in the mouth. Patient's breathing through the nose. It's very idealised. We like that to happen. What does the nose function to do? It filters the air. It warms the air before you breathe it. Now, a lot of patients always are chronic mouth breathers. So I think in those cases, you want to make sure that they can breathe easy through their mouth as well in those cases, so that you don't get a claustrophobic event where someone thinks, I can't wear this, I can't breathe. But you can see here the benefit of the treatment. And so, again, in someone with TMD, you would not consider starting them at 50% forward. You'd be considering starting them maybe at about 10% forward and work your way with the advancement process. And I think just finally, we know that certainly following up your patients, whether it be a occlusal splint or a mandibular advancement splint, always follow them up. Really important stuff. And secondly, and more importantly, you should be reviewing your patients. Even if patients have occlusal splints, you really should be checking those splints. I don't mean look at it and say, gee, that was a great splint they made in the lab. It's about saying, is it even? Do I need to polish it? Highly recommend that you do. Put your articulating paper in. Get them to manoeuvre the mandible. In a mandibular advancement splint, what you're checking for is retention of the lower device. Make sure it's still got a good hold on the mandible so that the mandible doesn't fall out, and therefore the effectiveness of what you're doing becomes much less. This was a small study, but I put it in. It showed that over a 2-year period of patients who had oral appliances, this mandibular advancement splint, there was no aggravation or certainly or excessive numbers of signs or symptoms of TMD didn't get aggravated over that 2-year period. I think the take-home message really is that you always pick your patients and you pick the cases that you treat. And my humble take on all of this is the more you know, the more you realise, dare I say to you, what you don't know. And the other thing that's very important is that when you're making a diagnosis such as TMD patients, you do not have to send every patient off for a sleep study. But what I would encourage you to do is consider that simple stop-bang questionnaire for men and the OSA 50, which I spoke about in my previous presentation for women, and the Epworth Sleepiness Scale. Your patients can be filling those out in the waiting room to give an idea of tiredness. It may not be relevant to the patient, but what a great service for your patient. They come in with jaw pain. You recognise that they've probably got a bruxism issue because they wake in the morning with a stiff or sore jaw. They're feeling really miserable because they're tired. They're also feeling pretty ordinary because they've got facial pain. And you're able to differentiate the diagnosis and get the appropriate management for that patient. It's a really very pleasant experience for you professionally. And I think lastly, I said that the last slide was the last one, but I forgot this little one. A sleep study is only required in patients where you suspect bruxism. So please do not feel the mandate like some colleagues do, where every patient they treat has to have the same treatment. No, they don't. But a sleep study is a valid proposition in those cases where the questionnaires indicate they might be at risk for having sleep apnea. Thank you. Is there any questions? Because I saw one pop up, but I'm very happy to answer any questions relevant to the topic.
Yeah, look, Professor Stubbs, I do appreciate that. I do have a couple of questions coming through. Before I go on to the questions, I'll just throw back there to that misunderstanding at the start there, mate. I didn't mean the oldest professor. I meant the most knowledgeable in no way. I think I'm now doing it with the grey hair, so sorry for that embarrassment. But just moving on to the questions. We've got a couple of questions coming in now, if I may. What question or questions do you ask your patients to be able to be more or to more accurately diagnose bruxism instead of do you grind?
Yeah, I think, look, for what it's worth, I never ask that question anyway. I always say to the patient, do you wake in the morning with a stiff or sore jaw? Now, sure, some patients can brux, and that could be clenching and not necessarily just grinding, of course, because bruxism is both. But the thing is, they may not wake up with a sore jaw. And you could say, well, physiologically, their jaw's coping well with what they're doing. But if the patient says they do wake up with a stiff or painful jaw in the morning, you can be assured they are bruxing. And that's one of the most reliable measures that I use.
Okay, that's great. Ben Gooden says, are you there?
Yep.
All right, sorry. Ben Gooden sends his well wish. We also have... is obstructive sleep apnea always caused by the tongue, or can the obstruction be caused by other structures?
Yes, well done, whoever wrote that question. Yes, it can be. I mean, like, it can be related, obviously, to the collapse of the pharynx. It's not just a tongue event. But obviously, when we bring the mandible forward, the primary structure we tend to stretch is the tongue, bring it forward. We do know, which is interesting, because you wouldn't necessarily think this, but we do know we influence the positioning of the soft palate. We get some stretching of that. And obviously, by stretching the walls of the pharynx, you're actually having an influence on the upper airway in its entirety. The really interesting thing, and this is just a personal observation, sometimes the fact that someone goes as far forward as they can with a mandibular advancement spin doesn't always correlate with better outcome. And what I suspect, and this is just a hypothesis that I put to you, is because there's a sweet spot, so to speak, where you can advance them, you get good opening of the airway, and as you continue to advance them, you start to get some narrowing or collapsing of the walls of the pharynx. And so it seems to be almost like 60% forward, they were doing really well, at 80% forward, they're suddenly snoring. And there are different reasons for that. Of course, blocked nose and the device not holding the mandible forward, but it can also be related to the excessive amount of stretching. So when we talk about sleep apnea, yes, certainly it's about the entire collapse of the airway. So it's the throat, soft palate, and the tongue. But when we make a mandibular advancement spin, obviously we have a big impact on the tongue position.
Yeah, thank you. That came from Shane Scott. So, yeah, thanks for that, Shane.
Thanks, Shane.
That's a cracker. Look, I know you've commented on this next question last week, but you may want to reiterate. I know your dislike to the 3D nylon tape, but have you used a nylon tape sleep apnea appliance? And if so, what do you think of it?
Oh, yeah, no, I have. I mean, look, when it comes to the world of splints, I'm out there. I like to try things. And the thing is, look, I don't mind them in a sense because they are, let's face it, thinner, less bulky. There is the concern I would have is perhaps, with the dorsal fin design, certainly how much does it hold the mandible forward? Is there any flexibility? But at the end of the day, it does have some advantages. And, and I have tried them in patients. And particularly people with very small mouths, and I found that really useful.
Okay, and how do you know when, or how do you know your MAS is working?
Well, a couple of things. I mean, I think the first one is, subjectively, of course, you can ask your patient. So let's say snoring's the issue. The Snore Lab is a fantastic free app that the patient can use that you can recommend. And they get a couple of nights free every so many nights. So it's a very nice subjective measure. The other one, of course, is how the patient feels. Again, that's subjective, but it's useful. And there is a thing called a night owl, which is ectosense, which is not the same as a formal sleep study, and I'm certainly not suggesting it is, but it's just a guide to determine if, in fact, they're getting a good response from the device. For most patients who have moderate to severe apnea, you usually would send them back to the sleep physician and get a formal study done because that's the gold standard, and that's what I would do. But obviously there are gadgets like ectosense you can use as a guide as you're titrating the device, because you can't exactly send a patient, I don't think anyway, once a month for a sleep study, which is with a sleep physician, just to check to make sure the position's right for the patient. Use some simpler tools, but always get the validation at the end. People that have mild apnea, often you'll find most sleep physicians, not everyone, but most, will usually say, if the patient reports they feel better, that's it. You don't need to send them back. But I always ask the sleep physician that refers to me. If I get someone that comes to me and they start talking about things, I always get a sleep study done before I make a device. Even if they just say to me, look, I don't care about apnea, I just want the snoring fixed, otherwise I'm going to get a divorce. The reality is, in those cases, I still get a sleep study, so I'll make sure that I'm not under-treating the patient.
Okay, just in real brief, Michael, if you may, Li Yang Lim has requested if you could summarise the points of when you should refer patients for a sleep study, please.
Yep. This is the brief summary, okay? Point number one is the patient's got TMD and they wake with a stiff or sore jaw. Point number two is if the patient is saying to you, or you ask the patient, do they feel tired? Is there a lack of refreshment in the morning? Does the patient snore? Now, the reason you're doing these things is because if you're making an occlusal splint for your patient with TMD, you don't want to compromise if the patient has an undiagnosed apnea, because it'll make it worse, just simply because of the volume of space the splint fills in the mouth, the tongue has less space. So they're the three really simple points. There's probably four there, actually. And then what I would suggest is, based on that, you then make a judgment call. And those questions, the questionnaires, they're really simple, but you can use them just to simply ask questions, yes or no, stop, bang, or OSA 50 for women. And it really gives you some sense of saying to the patient, well, I reckon we should probably get a study done in this case because you've got other symptoms which may or may not be related to your TMD. But before I treat you and if I make you an occlusal splint, I just want to make sure I'm not making another problem worse first.
Okay, one's coming here. Thanks for the presentation, Michael. Is there a role of the maxillary expansion in the treatment of TMD in patients with OSA? I recognise there's a lot of TLAs or three-lettered acronyms there, but what are your thoughts on that?
Yeah, I mean, I think certainly from the point of view of airway, upper airway, recognising in a patient who's, let's say, a child, 9, 10 years of age, and interventional orthodontics is phenomenal because, again, you can expand the upper arch if that's what's required. You look at skeletal growth, and obviously as an adult, you might consider orthognathic surgery over a dental device to help them with their airway. I mean, I've shared with you about mandibular advancement splints, but obviously the mandibular advancement might actually be a permanent treatment for that individual without the need for devices. And And so I think what I would do is when we talk about the assessment of a patient who's got TMD, I don't advocate orthodontics to treat that condition. What I do though is I always say something like, well, look, you've got a few choices here. One is surgery and obviously one is non-surgical. Most patients will go for non-surgical, but there are people that like the idea of having something they perceive as a quick fix. The problem is there's no such thing as a quick fix. Even those that have magnificent orthodontic surgery and orthodontics, that individual gets older in life, increased body weight. They can, in fact, actually still snore. But that is a very sensible approach. So the idea of maxillary expansion, looking at interventional orthodontics, very good for the upper airway, particularly in kids, or considering surgery and orthodontics in an adult with sleep apnea. But I certainly don't advocate orthodontics for TMD.
All right, and I'll just go to the last question now, Michael. We have where's the best place for patients to get a sleep study? Is there someone you recommend? Is there a group of people across the country or globe that you'd recommend, or where do you reckon best place that you could send them to be?
Well, there's some great look, for example, in Victoria, but a colleague of mine, Dr. Linda Schachter, who is a friend of mine, is Midley as well, but she's a fantastic sleep physician, and we've spoken and lectured together for years. On sleep apnea. She does Sleep Services Australia. They're everywhere. They can be contacted. The other thing is sometimes you can link up with a local sleep physician. There are places where you can actually, through the patient's GP, get them referred in and get a sleep study done. And each state would probably have an equivalent to home studies where people can be referred in and have a sleep study done at home. So they drive into the facility, they get attached and wired up, they drive home, the next day they drop the equipment off. So I suppose depending on what part of Australia you're in, you might like to have a look around your area to see if in fact somebody does that service, because you'll be surprised. There's a lot of the rural areas in Western and Northern Victoria where I look after a lot of patients. Believe it or not, the sleep physicians actually mail out, express post the equipment with a CD-ROM, patient assembles it, then the patient packages it and posts it back the next day. It's an easy way of doing it.
Yeah, Michael, it is real easy. I've had a sleep study done personally. I did a telehealth conference with my GP, who she recommended. Normally, most GPs have someone they recommend as well. They sent me down to a clinic just around the corner. I popped in after work around 6 o'clock, got wired for sound, as your words were, went home, did the study. It wasn't so bad, and then a couple of weeks or nearly a month later, unfortunately, during this COVID time, I got the results back because they need to go across a whole bunch of specialists. But it's quite simple, and I'd recommend those who have thought about it or are struggling or waking up with bags under the eyes, go and talk to your dentist, talk to your GP, and
absolutely
do it find resolution. You can see from what Professor Stubbs has been showing us how important it is, and the diagnosis and the importance of you guys and everyone here watching this to be at the forefront of diagnosis. I think is super important. But look, I'm getting a wave now from the back there, Michael. Is there anything you'd like to give us to wrap it up? Anything you'd like to finish on?
Oh, thanks. Well, look, one thing is I haven't mentioned before, but there is an education training program called from the Respiratory Dental Institute, which is ours. We actually educate colleagues online, introductory and advanced courses. So if you've got an interest in sleep medicine, dental sleep medicine, you're welcome to have a look at the webpage. And obviously there's TMD one coming as well, which Race Dental and us will be working together for. Thank you.
Oh, look, that's great news. If anyone would like to harass Professor Stubbs, he's can be found at drmichaelstubbs@hotmail.com. It's on the screen there now. Or go to michaelstubbs.com.au. Alternatively, for any laboratory advice, please don't hesitate to contact us at racedental.com.au or customer support at Race. My name is Matt Race. I can be called at matt@racedental.com.au. But thank you all. We've talked Professor Stubbs into coming back next year for another few exciting topics. So we look forward to seeing you all soon. Thanks for joining us. Thank you, Professor Stubbs. Your knowledge is always appreciated, and we'll see you all again soon. Thank you.
Thank you very much. Right, take care. Bye.